All right, welcome. That I'm Dr. J.D. Dahlberg, that I'm going to be speaking on the treatment of Hep C, and they changed my title. It was treatment of Hep C with the heart of Christ, actually is what I wanted the title to be, but with a heart of compassion. That I am a family physician, that I work at a FQHC in Greenwood, South Carolina. We're not a faith-based organization, but I would say we're a faith-friendly organization. Or actually, I'll come back and talk about that a little bit more because hepatitis C has really helped us with that, to be more of a faith-friendly population or a faith-friendly organization. We are faith-friendly. I'm thankful that I have the most staff that I've ever had from our organization here at this. So we work at a place, Bethany Center in Uptown and Ware Shoals. I've been able to recruit other doctors who want to come in and work with us, other providers that are interested in doing this. Before I start, I do kind of want to know the crowd that we do have. PA students that is free clinic. Do we have any free clinics that are working in here? Because there's definitely, I've got some things that we can talk about from a free clinic standpoint. That this is we geared towards that. How many other providers in the rooms? Nursing staff or social worker? Okay, that's good. Because this is. That I had someone in our clinic really convince me, not on Hep C, but that we needed to start doing pre-exposure prophylaxis. And I'm like, I do HIV, I'd be happy to do it, but I just don't think that will work. I don't know how to get them the medicines. And it was really someone who said, I'll get the medicines. You know what I mean? Like you help, I'll figure, if you see the patients and you start writing it, let me figure out how to get it. So hopefully there'll be no matter what role you're in, you can go back to your organization and be like, this is something we need to look at. This is something that we need to consider. So I'll go back a little bit that I like to go over our objectives. So partly, no matter where you're at, no matter what organization, what setting, I'd like to try and convince some people today that they can do Hep C, that it is something that if you haven't been doing it before, that it's something that you could start, whether you're in a private-based role, a free clinic, FQHC role. I think that it is doable. I also think that it's needed. So we'll go over a lot of medicine stuff today too, of the lab work, of just kind of the basic things that you need to do, the treatment options. I'll give you the warning on this right now. There are 2 medicines that we're going to talk about for hepatitis C treatment. That is it. That we are a primary care organization. We don't have any infectious disease doctors, GI doctors. It is us. We're completely primary care. Thankfully, that now there's an organization in the Southeast that's really helped us with our Hep C and HIV. And one of the doctors there who's a mentor to me is Dr. Ahuja, and he's just been great to work with. We'll give you that information. That they have a grant to help people. And so I'm going to talk about 2 medicines for Hep C. Dr. Ahuja, who's one of the smartest guys I know, he said, I have to do diabetes, but I never really know what medicine to write after metformin. And I'm like, yeah. He's like, so, diabetes is way harder than Hep C. And I'm like, yeah, you're probably right. I hadn't thought of it that way. So we'll talk about those 2. We'll talk about drug interactions. The drug interactions are not bad. Has anybody in this room ever written for Zofran or Diflucan? Raise your hand if you have written for them. Way more drug interactions than we're talking about than with the Hep C medicines. And then also, I'd like to help guide you in what's worked for us as to where we started, what treatment, what group we went after first, and what I think works, what's the easiest group to go after. And it's also the group in most need. So this is a funny map. This is a map that I showed my dad, I don't know, when I was like in 7th or 8th grade, that I am originally from. My parents still live. If you see where the 3 is, that's in northern Minnesota. My mom and dad have a farm there, and I showed this to them. It was almost a little more specific than this, and I'm like, Dad, you have chosen to be a farmer in the hardest place to grow things. I'm proud of that actually my great-grandfather moved here from Sweden, and he was like, I know how to live up here in northern Minnesota. I can get through the cold. I can, I mean, it's crazy. When they moved over from Sweden, they would like dig an area in the ground. They would go to the lake, and in northern Minnesota, the lakes freeze completely, and he would chop out blocks, from the ice on the lake, pull them out, and then bring them back to his place, line this kind of underground area, then put the ice blocks in it, and line it with straw and whatever they had. And then, so during the winter, they didn't have to worry about things, about their milk or their meat. Then during the whole summer, that they would store it down there, and this was, they didn't have refrigeration. And he's like, I'm from Sweden. I can live in northern Minnesota. If he would have moved to South Carolina or South Texas, he would have died. They just wouldn't have been able to make it. So I love that I have that. That is my background, and we don't have an HIV or a Hep C population in that area, but we have a lot of farmers and a lot of guys that are just good at doing stuff. They're construction workers, and so when I was 16, our church took a trip to Voice of Calvary Ministries in Jackson, Mississippi. That one of the founders of CCHF, Dr. Perkins, he started an organization originally called CCDA, Christian Community Development Association, but that wasn't enough. He said, man, these communities that we're developing, they need health care. And so he was one of our original founders for CCHF. I didn't know this when I first started at CCHF 12, 13, 14 years ago, that if you mention Dr. Perkins, it trumps all other stories. It's about 12 or 13 years, I was talking to Steve, and I'm like, we're starting a clinic. I would like it to be a CCHF affiliated clinic. And Steve was like, wait, who are you? And who are you working with? I'm like, well, it's just me. I'm coming back. And he was like, did you do a rotation in Memphis? I'm like, no, sir. How about in Lawndale? I'm like, no, I've heard of Lawndale before. And you're like, how do you know about this? And I was like, well, how far do you want me to go back? When I was 16, I went and saw Voice of Calvary Ministries and what they did in their community. And he's like, oh, Dr. Perkins. Okay, all right. Then he's like, that all makes sense then. So he set me on a path, really, that I wanted to serve the underserved, and to reach out to populations in great need. So at 16, I had to find a school that was a school where I had a good pre-med program, and they'd also let a 5'8" white guy play basketball. So that led me to Bethel University, which is a Christian university in Minnesota. Nothing crazy or anything like that, but I did get a crazy question when I was trying to get into med school, which also then put me on a course towards treating Hep C patients. This is the Minnesota Gopher, in case this was the med school I wanted to get into, is where I was from, the easiest I thought to get into. But the guy I was interviewing, guy who was interviewing me to get into the school, asked me a question on that interview day, and he said, because you went to Bethel, I didn't think that much of it, because you went to Bethel, could you treat HIV patients? Good side note, if someone asks you a question, it's always good to, you can answer the question. I could have just said yes, but if someone does ask you a question, it's always good to be like, why do you ask me that question? That came in handy during COVID. People, patients would come in and say, I got to ask you a question. Did you take the COVID vaccine? I could say yes, but I always wanted to follow up with, well, why do you ask me that question? And it was interesting to have, maybe especially my 60 to 70-year-old, black diabetic population would say, well, I know you've called me and tried to get me to come in early as soon as you got availability, but I didn't know. I've heard a lot of rumors, a lot of bad advice, but if you got it, I'm okay with I'll get it today. And I'm like, okay, well, great. I'm glad I asked why. Ask another patient why, and say, you get the COVID vaccine? Yes. Why do you ask that question? Well, because I no longer want you to be my doctor if you've gotten the COVID vaccine. I'm like, oh, okay, that's very different responses as to what I would get from that. So I asked this guy, I was like, yes, I can treat HIV patients. I'd never met an HIV patient. I guess I had a basketball background, so I knew Magic Johnson had HIV, in 1990 at that time. So, but I could treat HIV patients. Why do you ask me that question? Because you went to Bethel. Answer still yes, but why? Because I went to Bethel, you don't think I could treat HIV patients? Because it's a Christian school. Answer still yes, but why? Because it's a Christian school, do you think I can't treat HIV patients? He was like, well, just from a Christian perspective, I've met people that are, they would be against helping someone, if they came from a homosexual lifestyle, or if this could have been any question. It could have been Hep C, Suboxone, if they have issues with drug addictions, or, that's something that, coming from a Christian background, that they would not want to deal with. That's not something that they would want to touch. I was like, oh, okay. I guess I can see where I'm sorry you've had that experience with Christians before. I was like, I didn't, yes, it was a Baptist affiliation. I'm not a Baptist. I just consider myself a follower of Christ. And, my answer to that question would be, if Christ were alive today, he would be hanging out with HIV patients, or patients that need Hep C treatment, or that need Suboxone. So if I call myself a follower of Christ, which I do, that I should be more likely to be treating HIV, now Hep C, Suboxone patients, because I'm a follower of Christ. And the guy looked at me and he said, well, that's a good answer. You're in. And I'm like, what do you mean I'm in? Where are you going with this? And I'm in. He was like, I really don't like basketball players, and I don't like Christian. I'm an atheist. And he was like, that's a really good answer. He was like, that's going to make me rethink some things. The other guy, I think he'll like you. I'm the one who wouldn't have liked you. So yeah, you'll get it. You'll get into school here. And I'm like, that was crazy. But what he asked me, that question, really had set me down a course to be treating Hep C patients, today. So it first put me on an HIV background. Thankfully, I did my training in Greenwood, family practice residency. We had a lot of HIV patients. We still have a lot of HIV patients. So this was starting in 1998. We would take care of them in the hospital. As a family physician, thankfully, I was able to continue to treat those patients when I started in clinic. I worked at a FQHC at that time, and had assistants. And that was my background. And then something happened around 2012. So the National Notifiable Infectious Conditions, this is really looking at more so tuberculosis and HIV. So this is deaths from tuberculosis and HIV. So right around 2012, something changed. This is deaths from hepatitis C and deaths from HIV, tuberculosis combined. The numbers flipped, where there was a big push to say, we don't have enough doctors to treat HIV. We need to move this into the primary care setting. Hard to do. A lot of people are nervous to take HIV in a primary care setting. But then things have changed, and they continue to change. This correlates with the opiate epidemic. As the numbers have grown, the numbers of Hep C cases have just risen quickly. And Dr. Ahuja, again, as he's said, I quote him, for infectious disease doctors, hepatitis C became the new sexy. That this is what we needed to focus on. He's like, I need to shift from trying to train primary care doctors. He said, we still want to do that, but we need to help. How can we help you with Hep C? And we started to need a lot of help with Hep C, because we started seeing just a lot more patients with Hep C. This is another way to look at it. Prevalence rates. And this is a little bit old, 35,000 new infections a year. And this number is coming down. We were hoping that the pre-exposure prophylaxis, the PrEP, would lower that number a lot. In our experience, that's a great option. It's just hard to get patients to come in and take the medicine. And we have worked on that, fitting in with who we want to be serving. But hepatitis C, it continues to rise, 50,000 new infections a year, and I think that number is even higher than that right now. So it's definitely, if you're not seeing it now, that you're going to continue to see it. We have a little bit of I think we had to tackle this a little bit sooner, that Greenwood has a ton of drug recovery homes in our area. Anybody have drug recovery homes, kind of that where after someone, they'll go live there for a while, and so we really tried to partner with them and help them and say, how can we help you with this? As a FQHC, we're like, you can come see us, and it's going to be $20. We're going to help you get your labs, and so we really had to tackle with this a little bit sooner. But I do think everybody's going to be looking at it, and there's just not. You're going to be looking at patients in clinic that they are not able to get treated for Hep C because there's just not enough providers that are doing it. All right, so let's talk some medicine. Let's go back a little bit. Talking about the Hep C virus. So it used to be, I could say 80-20, 80-20. I would say if you were exposed to Hep C at some point in time, that 20% would clear it, and 80% would keep it. So 20% would clear it without any medicines, and 80%. That number has shifted, and it's shifting because we're seeing a younger population get Hep C. And as a younger population that just have a better immune system, they're naturally able to eradicate the Hep C virus from their system. And so we're not seeing as many in the chronic, maybe even as low as that 50. It depends on age. So 55 to 60% become chronic if you're talking about a 20-year-old. If it's a 70-year-old, then you're up at the 75, 80%. That we were, from an age group perspective, it was interesting. I was talking to Joey, his wife, last night, and they work with the hemophilia population. And so the older population that they work a lot with that group, and the older hemophiliacs, so many of them had Hep C or HIV because of blood transfusions, because they required so many blood transfusions, and eventually they had one blood transfusion that had Hep C in it, or had HIV in it for that matter. And we still are finding patients like that. So of that chronically infection, 20% of them will go on, and it takes a while, usually in that 15 to 20 year mark, before they'll go on to develop cirrhosis. So still not a huge percentage of that, and it's multifactorial. It's hard we don't know of the people who have chronic Hep C as to who is going to go on and develop cirrhosis of the liver. We do know that there are certain things that will make it more likely, that depending on their alcohol use, on other things that can just be harmful to your liver. When you have that and you add it to chronic Hep C, your risk of cirrhosis will go up. And then of those patients with cirrhosis, then you'll have a group of them that go on to end-stage liver disease or hepatocellular carcinoma, HCC. That's a big thing that and we still have to look for that even in our Hep C population. It has changed now because of younger people getting it, older people that have gotten it. It's just pretty standard that United States Task Preventive Services check everybody once for Hep C, and this has been great from a nursing perspective. That say, hey, this is just. It's really good on a medicine side. We're a little bit on the OCD side. We have Epic as our EMR, and so there's a little checklist on the left that says, this person has never been checked for Hep C before, so we check Hep C, and then it's really helped us get a lot of diagnosis that we probably would have missed earlier. And I just want to show this slide so if you diagnose Hep C, said treatment should be initiated without awaiting spontaneous resolution. Now, I still, if I have somebody, every once in a while I'll be like, they recently, it's got to be a short window where it said, I just started using, injecting IV drugs, fentanyl recently, and they come in and they're Hep C positive. I may give them 3 months to see if it would clear, see if they fit into that, as high as 30 or 40% of people that would clear it. But the goal is we really just want to go ahead and treat people. Everybody who's got Hep C should be treated. That was not the case when, you may hear rumors when the medicines first came out, there was so many people, and this was, there was a time period where it was weird. Well, let me jump ahead to that one. I'm going to come to a slide that will better explain that. This one, okay. So you'll talk to patients that say, I don't want Hep C treatment. After they've been diagnosed with Hep C, they're like, I don't want it because they know somebody who in 1991 or previously went with interferon. And interferon was an old medicine that we used for Hep C that you would have to take it for 6 to 9 months. And I took care of a couple patients like this that they said, when I took that medicine, I felt like I had the flu, like the achiness from the flu every day, for 9 months. And so a lot of people didn't finish that treatment course because, it's just, and the bad part with that, if they had gotten Hep C from, let's say, IV, opiate at the time, that 6 months into it, they were like, forget it. I'm going back to, I'm going back to opiates. This is horrible. And then the really bad part about it was only 60% effective. And so you're like, well, you have felt horrible. You made it through the treatment of 9 months. Congratulations. No, I'm sorry. It didn't work. And right now we don't have any other treatment options. And so then right around 2011, 2013, these direct-acting antiviral medicines, which have some similarity to HIV medicines, there's some carryover there that they came out. There was a time period where we were saying, actually, you have Hep C. Don't worry about treatment in a year or two. These newer medicines are coming out. Just hold on because it's going to be so much better. You're waiting. Avoid things that could cause damage to your liver. But it's just going to be so much better when these new medicines come out because they're 97, 98, 99% effective. We don't say. I'll see like 98%. I really feel like if somebody has taken one of these medicines and it doesn't clear, they probably, it wasn't the medicine. Either they just didn't take it or they got reinfected with a different, Hep C virus. 'Cause it just works really, really well. So well, in fact, that, we typically want a 8 to 12 week course. As we're taking care of this recovering drug population, they'll be 4 weeks into the treatment and we'll lose them. They'll relapse and they'll be gone. We can't find them. We can't get them their second bottle of medicine. And so as we're trying to get a hold of them, we just can't. They're on the street. 9 months later, they come back. And so when they do come back, they're like, I was 4 weeks in and you guys would have helped me. And I regret this so much that I didn't come back and finish my treatment. And I'm like, well, we're going to help you either way. But first, let's just check a Hep C viral load and see if you've cleared it. They're like, I only took 4 weeks of the medicine. And so we'll check a Hep C viral load. And we're like, no, you're cured. It worked. So even with a short, definitely the 8 to 12 weeks is a longer time. The only people we really don't treat is someone with like severe cirrhosis, hepatocellular carcinoma, that we don't think they're going to live for 6 months. I don't know why they set the number at 6 months, but they're like, well, why take a medicine for 3 months if we really think you only have 6 months left to live? They just work so well that's why we want to use them. So I want to try and convince you that it's easy, to treat Hep C patients. It's definitely, the medicines are getting much easier to obtain. The other thing I want to try and convince you of, one, as followers of Christ, we need to be. We need to be treating these patients. But it's also a fun group of patients for me to take care of. It's probably one of my favorite patients to take care of. A couple years ago when my wife came with me to one of the conferences, we were in Atlanta. For those of you who don't know, we kind of move around. The conferences for CCHF moved to different spots. They've been in Oklahoma City, Chicago, Atlanta. So Atlanta was nice. We were down there for a couple days. And I don't know, maybe I chose the lectures poorly. So she came with me to a couple of lectures. And about 2 or 3 lectures into it, she leaned over to me and like, is this just like a conference for burnt out people? And I was like, no, that's my wife is a college professor, and she's got this natural rhythm that she can be having a horrible semester, okay? But she knows that, students will be cheating, they'll be giving her a hard time, that it'll just be horrible, that they won't laugh at any of her jokes for like 2 months straight. And she's like, but at the end of that semester, that she's like, well, then it's done, and I get a whole new group of students, and there is even if it's a bad time period, that stress kind of gets relieved. Then it's summertime, then she starts to fall, she gets a whole new group, and again with that group, that it's good, that the semester will change, she gets refreshed, as long as I take her someplace warm over Christmas time, then if we take her to northern Minnesota, maybe not so much. She's like, well, that was not refreshing on that one. This is a refreshing group of patients to take care of, because taking care of patients in a long-term primary care setting, you don't always get to see the fruits of your labor, and that can be, I think, contribute to people, the hardness of things. And so I'll skip to, this is one of the things that's so fun, is you get to see somebody and said, you're on a track where you could go on to cirrhosis, and they all think they are going to go on to cirrhosis and die. That I think they've had a friend of theirs that has had Hep C, they've known it, the drug addiction community and the recovery, they're very close. They know people, and they know other people that have been and that have Hep C, and they've died from Hep C. So they have this thought that they are going to die from Hep C. And it's very few things that you can take a look and say, well, you're cured. And a lot of them, you're like, I really don't need to see you anymore. That you're fine. And it's not that often that we do get a chance, from a primary care perspective, to say, you're cured. It's a fun word to say. I like to say it, tell them they're cured. I can write that in my notes, like Hep C viral load was undetectable. Tell them they're cured. Then they come in for their visit. You're cured. That I don't get to say that very often. So it's refreshing from a provider perspective. It's fun to see patients like that. The other thing, from a spiritual perspective, this is a group of patients that really need help. They need hope. That I really I want to make sure I say it right. Pastor Mike, that was such a great sermon last night. But sometimes when I'm at a CCHF conference, I'll hear something like what he said last night. Jesus goes to the area of greatest pain in a person's life, and he brings them dignity. And I was like, I got to write this down. That's such a wonderful statement. But sometimes you're at a CCHF conference and you're like, that was so great, that was so awesome, and you're at the high of here, and then you go back to clinic on Monday and you're like, wait, what do I do? How do I do this? And this is one of the best examples. When he said that, I was like, I'm glad I'm doing a lecture on Hep C, because for a lot of patients, this is the areas of greatest pain in their life. And they don't know what to do with it, because they've looked at it and said, I've conquered my addiction, I'm not putting a needle in my arm anymore, but I still have Hep C and it's going to kill me. This sin, this problem, this thing that I've done before, I can't shake it, that it's not going to go away, that I'm left with this, and it makes me unclean and it makes me dirty, and I'll always be that way. And they lack that hope, and they're like, this is what I deserve. And so this comes up very frequently where I'm able to share. I'm like, well, hey, this is great, because just like me, Romans 5 is one of my favorite chapters, because I was like, just like me, God demonstrated his love for me in this way. While I was still a sinner, while I was unclean, he died for me. He gave me a gift that I didn't deserve. And I know you feel unclean now, and I feel, you feel like you're never going to be able to shake this, but they view it as, they get treated for Hep C, and we help them get their medicines, and they feel like they've gotten a gift that they don't deserve. And so it's a fun thing to treat. So it's a great way to avoid burnout. The patients are super grateful afterwards, because again, they've given a gift that they're like, I thought I was dying from Hep C. I thought I was going to have cirrhosis, just like a lot of my friends. And I'm like, nope, you're cured. And they're like, the level of gratefulness is fun. The other thing that is helpful, that it is a tool we're not a faith-based clinic. We're not a Christian clinic. Your service to Hep C patients, but this other, HIV, Suboxone patients, drug addiction patients, it is a tool that you can use. I'll give you an example that I've gone many times and said, I want to treat Hep C patients. Nobody's getting them treated from a primary care perspective. I think we can do this. Let's open this up, and so that we can, establish this program to get people in. And definitely, my administrators will say, "That sounds awesome," and I'll say, "Thank you, because this helps us fulfill. We're doing this because Christ has called me to do it. I need to take care of, this is type of patient. This is great." And they're like, okay, that they don't know quite what to do with that, that they're like, yeah, we want to treat HIV patients. We want to treat Hep C patients. We need to treat the marginalized communities and help in our community. But I'm like, and I'm going to do it because Christ has called me to do it. And they're like, well, we want you to do it, but we're not sure. It has been a tool. It's been a tool for me. And I think it can be if anybody's if you're in a private practice and a hospital-based practice, you're like, I want to start seeing Hep C from a primary care perspective, and they'll probably say, great. And you're like, but make sure you follow that up with, that's great, because Christ has called me to do this, and that's why we're going to do this. They're like, well, we want to do it, but it's almost something people can't say no to. So be bold in tying it to your faith. They say, I'm called to do this. All right, so patients that you will see on a pretty regular basis, I think. 59-year-old male, say uninsured, that his LFTs had bumped up, his AST, ALT are in the 68 to 91 range, not bad. INR is still fine, hemoglobin's good, platelet count's a little bit on the low side. Lower platelet count will be a signal of worsening cirrhosis, or if they're developing cirrhosis of the liver. We see a lot of patients with elevated, this is not bad, but this is pretty normal. It's always amazing to me when I see someone with LFTs in that 80 to 90 range, but then when we work them up for cirrhosis, they're like, wow, they've got severe cirrhosis of their liver, even though the LFTs aren't that bad. This patient ended up that he's never had an ultrasound, that no history of cirrhosis. He's never been treated for Hep C, the treatment naive. He's never been treated before. HCV genotype, that used to matter. And the great thing is it just keeps on getting easier and easier to treat Hep C. It really doesn't matter what their genotype was. It used to be we had medicines that we would use this genotype for 1, 5, and 6 and use this other one for genotype 2 and 3. Now they all work. Can you see the HCV, the Hep C viral load? So just like from an HIV background where I was checking HIV viral loads, we check a Hep C viral load. It comes back as undetectable, if they've cleared it completely. But this patient's level is 2.8 million. Hep C viral loads, they don't matter. All that they matter really is if they're positive or negative. In HIV, the higher the viral load, the worsening, over time their immune system will become. It doesn't matter if it's 400,000. We'll see levels of 12 million. And it's interesting to see a level of 12 million and be like, but no signs of cirrhosis, that they're okay. There's one thing that you do have to take a look at from you want to stage where they're at. You want to try and determine, are they in cirrhosis or are they not in cirrhosis? So there's lots of tests, and depending on what you're doing, that transient elastography, or we call it a fibroscan, is a test that we can do. In South Carolina, their Medicaid for a while, they were like, okay, before we'll treat this person for Hep C, that they need to get a fibroscan. And at the time Medicaid came up with that rule, do you know how many fibroscanners there were in the state of South Carolina? 0. They had a lot of rules at first. They were like, we're only going to treat the people who are cirrhotic, that have liver failure, that we're going to start with this, because there were so many people that have been waiting for these meds to come out. But I don't have a fibroscanner. I have never ordered a fibroscan in my life. Our town didn't have one until recently, and it's still a little tricky to get one. Our hospital doesn't have it, and I'm dealing with more uninsured patients. But we have a blood test called the Fibro test, or the FibroSure, which is, it's an easy test. It'll just tell you, are they F0, F1, F2, which is like, well, we don't have cirrhosis, or are they in the F3, F4? But there's other routes too. This APRI and FIB4, they're very easy to do. It's really just where you add, you can pop in the formula. It's liver function test, platelet count. One of them makes you do an INR. Nothing that's expensive to do at all. So from a free clinic perspective, it's not hard to get these labs. Maybe someone will push back and say this FibroScan or this FibroSure test is too expensive. Then do this APRI or the FIB4. It's a really good way to look at it. The other thing is you don't need to do an ultrasound anymore, not in the workup. Only if someone has cirrhosis, like a F3, F4, then you want to get an ultrasound. The only thing the ultrasound is looking for is hepatocellular carcinoma. It's not a great test to tell whether it has cirrhosis or not. So it's insensitive for cirrhosis. Now, if someone has bad enough liver cirrhosis, their risk of hepatocellular carcinoma goes up, so you just want to make sure that they don't have that before you start on treatment. And I mean, I've never ordered a liver biopsy. The liver biopsy actually isn't very good because the liver can change, and as people were doing a liver biopsy, maybe they'd hit a good part of the liver. You're only just getting one little spot, or maybe you're hitting a bad part of the liver. So really the FibroScanner is the best test because it really shows the stiffness of a liver, and so if the liver is stiff, it's cirrhotic. If it's not stiff, then it doesn't have it. Every once in a while, you'll want to do two of these tests because you're like, well, one test showed it was like a F2, the other test showed it was F3. I'm kind of on the fence of this one. You do want to know if someone has cirrhosis, because if they do have cirrhosis, that you're going to ask them to do liver ultrasounds for every 6 months, even after they're successfully treated for the rest of their life. I think that's going to change at some point in time because nobody does it. It's just hard to get. I mean, you can order it, but patients don't want to do it. So you do want to know whether they have cirrhosis or not, more so for that reason, whether they have to get an ultrasound or not. So this was the medication list the patient is on. This was a Suboxone patient. So as you're going through your clinical considerations, all right, do they still have Hep C? Have they cleared it on their own? Nope, they have not cleared it on their own. Have they ever been treated before? It's just, there's one other medicine we use if they've been treated before. I mean, I probably would pass on that starting out. I'm just going to focus on the treatment naive. Do they have a genotype? We really don't need that anymore. And then did we stage their liver disease? You also always want to test on everybody to see if they're HIV positive or negative. The reason being, if they are HIV positive, you actually want to establish their HIV treatment first. And then after that, then start their Hep C treatment afterwards. These are the medicines. When we work with Vanderbilt and USC, they always say the generic names every time, and I'm not going to do that. So the original one you probably heard of, Harvoni, like I was talking about, that treated genotype 1, 4, 5, and 6. And then we had one called Zepatir that only did 1 and 4. But now we use Maviret, the second one, and then Epclusa is the fourth one. And as you'll see, they're pangenotypic. It doesn't matter, they work for everything. Vosevi on the bottom, that's the drug we use if someone if they've tried Maviret or Epclusa before, and then they get reinfected, and then we'll use Vosevi the second time around. This is the labs. This is great to use if you're in a private practice setting or a free clinic setting. This is called, they've come up with a simplified HCV treatment. These are all the labs that you need. So they do want to know, just a Hep B surface antigen, HIV test, Hep C viral load. Off these, you can do the APRI or FIB4. So they keep on making it easier that you can order less tests. Now, insurances don't always do this because insurances sometimes will say, well, we want this test, we want an INR on this patient. I'm like, okay, well, I'll get an INR if that's what I have to do to get them approved. So after we've worked them up, we figured out if they had cirrhosis or not. Treatment options, most of the time, we just always use Maviret or Epclusa. And so this is a little bit on these two medicines. So Maviret is 3 pills a day for 8 weeks, and Epclusa is 1 pill a day for 12 weeks. And I just have to ask the patient. It's always interesting to say, do you have a preference as to which one you would take? And they're like, oh, I can't take 3 pills a day. And I'm like, well, you take 5 other pills. So they're like, yeah, but 3, no way, I can't do that, But then other people, they're like, I want to take the shortest regimen. I want to be 8 weeks so I get the virus out of my system as soon as possible. Anticonvulsants with both, but that's true with anything. I mean, any drug you write, if someone's on Dilantin, you're like, okay, let me check for drug interactions. But the big ones is statins and then really proton pump inhibitors. So if someone's on Maviret on the first one, that you want to make sure that you switch them to Crestor or Pravastatin, just one of the easier ones to take. Take them up. They really shouldn't be on Zocor. I don't write Zocor. But if they're on a high-dose Lipitor, 40 or 80, you probably should switch them to Crestor. I had a patient who recently had a stroke, and she was on high-dose Lipitor 80. And so I was like, well, I actually sent off her medicine. I'm like, there's no way you're going to have the medicine back, when I see you back in 3 weeks. And she came back and was like, oh yeah, I got it a week after you sent it in. I saw her one time. We did the lab work. I'm like, I'm just going to send this in. Her insurance paid for it, and she had it like a week later, and she'd been on the high. I was like, oh, I'm going to have to change the way I do things. Because I was like, I'm just going to wait and change the statin dose when you get back. But I'm going to change them now right away because it's starting again to get so much easier. This would be the one thing, if they really have bad acid reflux and they can't come off a proton pump inhibitor, they probably shouldn't be on Epclusa. Then you'd want them to be on Maviret. And there are definitely some patients that you're like, I can't come off my omeprazole. That's an impossibility. So then make sure you get them on Maviret if that's the case. Or they'll say they'll come off of them, but they're like, I tried, I was wrong. I had to go back on. And then from a Suboxone perspective, really it's just minor drug interactions. If you have someone on Suboxone, definitely put them on, treat them for Hep C. So again, I came at it this way, and I'm hoping that, I don't know if there's anybody here. It took me a couple CCHF conferences before I started treating patients, with Suboxone. I came from the HIV background, then I did Hep C, but all my Hep C patients, not all of them, but a lot of them, they needed to be on Suboxone, and I wasn't doing it. And so really my prayer for this lecture has been, there will be people here that are like, I'm doing Suboxone, but I'm sending out all my Hep C to someone else. And you know what? A lot of them don't go. They don't go get it done. And so I'm just going to start doing it because it's getting that much easier. That I think that's, if Rick Donlin was here, I'd be like, can you treat Suboxone, and a patient without treating their Hep C? Are you doing what Christ wants them to do in their life? He needs to make a controversial statement. But I do, you're like, I can take care of these things, so then I think we should, because there's a much better chance that they'll get it done. So we see people, once we get them on the medicine, we'll see them, typically we see them halfway through, but the labs really don't matter. I definitely have patients that they're like, yeah, they never came. They just got their 8 weeks or their 12 weeks of the medicine. It really doesn't matter. Nothing bad happens to them. There was a risk factor that if they had hepatitis B, that hepatitis B maybe could reactivate if they had like a latent hepatitis B, so that was one of the things we want to check for. That really doesn't seem to be the case. I do follow people up. For me personally, I follow people up because we need to make sure that we can get them their second month of medicine or their third month of medicine. So that's why I really follow them. I really don't worry about the labs. I'm like, okay, you got your first bottle. How do we get you your second bottle? Because sometimes the bottle gets sent to our clinic, sometimes it gets sent to their home, sometimes it gets to a pharmacy. And so that's really what I want to know is like, did you get your medicine? Are you on it? And that how do we get you your second or your third bottle? So I think it is worthwhile. I mean, that could be a telehealth visit or a phone visit. If you had somebody that were like, okay, we're just double checking in. That's been a life changer for us. We had a nurse originally that she kind of took the lead on helping us get Hep C medicines, helping us fill out the paperwork, and then following up with patients. She got moved out of our main site into another site, not my choice, and it wrecked things for us for a while. Patients couldn't do the paperwork, and then she had trouble getting a hold of them. And so we've just brought a nurse. We did get a grant. And she's back in, and kind of one of her jobs is to keep track of our Hep C patients, help them get their medicine, make sure they get their second bottle, their third. So if you have the ability to do that, it is nice to have a kind of a nurse champion to take care of that. So again, check it, Hep C viral load after they've finished their pills, whether it's 8 weeks or 12 weeks, do their Hep C viral load. Should be that they're undetectable. You can tell them you're cured. You're like, you're cured, but I'm going to see you back in 3 months again, just to tell you you're cured again. So 3 months after they finish their treatment, that we see them, we do a Hep C viral load one more time. We do their liver function test, and if their liver function tests haven't come down any, then you should look for something else that's causing their liver to not get better. And it's crazy that you'll see patients that have severe, F4, bad cirrhosis, their LFTs are way up. They finish treatment, their LFTs just completely normalize, everything looks great. Still the guidelines are, because their liver was so bad at one point in time, there's been enough damage to it that's been done. You definitely lower their risk by eradicating the Hep C, but enough damage is done that a spontaneous mutation could happen in the future and they could develop hepatocellular carcinoma. So that's why you continue to check. But the liver function tests get significantly better. I'm going to have everybody pull out their phone, and I would like you to pull in hcvguidelines.org. hcvguidelines.org. And this is a great website that if you want to read more on testing, monitoring Hep C, but looks like this, we'll get to, and then I just go, for most of us, the initial treatment of Hep C infection. Let's pick a genotype 1, treatment naive, and we'll say they're 1 without cirrhosis. Treatment naive genotype 1A without cirrhosis. This used to be more important. I still thought I would go through this kind of to take a look at it. Now they almost always tell you that use Maviret for 8 weeks and Epclusa for 12 weeks. So I used to do this a lot. I really don't need to do this much anymore, but I still think it's a really good website to be able to know the hcvguidelines.org so that you can pull up, this is where I got this slide from, but it's very easy to get to that slide. That they still ask the genotype, but like I said, you almost don't need them anymore. So on this patient with a viral load 2.8 million, let me skip ahead. We don't have time for 2 of them. We'll put this patient on Maviret for 8 weeks and try and follow them up 1 week through. At the end of that 4 week, I do check LFTs at that point. We check a Hep C viral load. Now it gets a little bit tricky because when they're already undetectable, sometimes they don't want to come back. But by the time they finish that, they get on the second bottle and then they do great. So in our experience, this is where I started, and I think this is a good way for most people to start. If you're in a free clinic, you can't start with insurance and Medicaid. It can be tricky. There's a lot of hoops that you can jump through. It's getting easier. In the state of South Carolina, we still have to present our Medicaid cases. So if I have a Medicaid patient, I have to present it to an infectious disease doctor, which that's why USC has been super helpful. And I'll give you their contact info at the end. But a lot of states don't have that they'll let you, just go ahead and treat them. Insurances can change because they'll ask you for different things and you kind of have to jump through their hoops. I will say something that, how many FQHC people do we have here that, so there was a time period, I hesitate to say this, but it was Harvoni, and Harvoni was $30,000 a month for 3 months, and so that was the treatment. And so we have a 340B pharmacy, and Medicaid and insurances were letting it send to our pharmacy, but our 340B price wasn't $30,000, it was more like $5,000. And so my CFO was very happy when we treated a couple of Hep C patients, and we were like, our pharmacy just had a $75,000 profit off of one patient for 3 months. Insurances and Medicaid have really tried to clamp that down quickly. They're like, we want you to send it to our pharmacy. Again, my EMR has been helpful with that because they'll even direct me to say, Maviret is on formulary. Maviret's a lot cheaper, that it's somewhere in the $6,000 to $8,000 for 2 months. A month for 2 months. So definitely insurance has said, we want you to do this, and we want this patient, it could only be filled through CVS Caremark Pharmacy. That was that one patient I was talking about. I sent it, and they just sent it to her. And like, whoa, that was quick. But I wouldn't worry about that. If you're looking to say, how can I start with Hep C? The insured patients, the Medicaid patients, they do have options. They can see a GI doctor. They can see an infectious disease doctor. Start with a group that is unfunded, that is not insured. With the Epclusa, when we first started seeing patients. We started with uninsured patients. And so we're like, okay, we're going to try and go through a drug assistance program. We used at first Gilead's, and it was for Harvoni. And it was $30,000 a month for 3 months. And I was like, well, I don't know how this is going to work. But you always have to help someone get through the paperwork so they have their medicine. It's not bad paperwork. Sent it in, and they mailed, 28 pills. They don't want to send you 30 pills. It's got to be 28 pills. They don't want you to do, in insurances too, if you send it for 30 days, they're like, no, this is a 8 to 12 week regimen. So you do 28 pills. If you spend in 30, they kick it out. You learn that, some of the things that they will do. So we got a bottle like $30,000. I was like, wow, they just sent it to our clinic. So one patient, $90,000. And I was like, when are we going to be able to say we have treated $1 million, worth of Hep C? Well, 11 patients. It wasn't that hard, and then all of a sudden, all right, now we're up to 55 patients, 5 million. We hit 10 million. I'm like, they're going to cut us off at some time, But I just think they're making so much money off of this that it doesn't matter. They use it as a tax write-off. I don't think you're going to get blackballed. We have not been. But this is the area that is, I think, the best area to start. In fact, so much so that we have patients that are like, hey, pretty soon I'm going to get insurance and I'm going to get Medicaid, and so then I can get maybe we can get my Hep C, or they think I can get my Hep C treated because then I'll have funding. And I'll tell them, I'm like, no, hold on, we got to put in your paperwork first, because I brought it just so that people would know. This is for Maviret to fill out for their patient assistance program to get their medicine. It is 2 pages, Like I said, with Medicaid, I'd have to present it on my lunch break, to an ID doctor. I'm like, no, let's just, and the questions that they ask, it's so easy that, they're like, what kind of doctor are you? Okay, I'm a MD, DO, hepatologist, or infectious disease. Okay, I can put MD, and all they ask for is like, fibrosis score. They don't want all the labs, and so it's been super easy to get. We're like, let us treat you there. I showed you the wrong 2 papers. Here's my 2 papers. As the labs that they want: fibrosis score, have they ever been treated before? Do they have drug allergies? What other medicines are they on? Okay, and then we fill it out, and that they, every once in a while, it's kind of, I don't know how they do this, but they'll send it back, and they're like, oh, this patient has Medicaid. I'm like, oh, I guess they do their research. But they're happy to give us the money, because, they do it as a tax write-off. So that's where I would start. I would start with doing, Maviret or Epclusa, and just going through, start with that population. We're starting to get patients referred to us. We have a free clinic that refers patients to us. We may actually have to, on some of our funded patients that are getting referred to us from a primary care, they're like, they could see the GI doctors, and the GI doctors can write it for them, because they don't have to, especially if it's Medicaid, because they don't have to present it. But I think it's just easier to get them into us, so they send them to us. So that this is USC and Vanderbilt, but anybody's going to be able to log into these if you wanted to. The Southeast Viral Hepatitis Interactive Cases, they do them on Wednesdays over lunch break. If you want to present a case, they are definitely set up for a person who's never treated Hep C before, and to just say, here are the labs I got, what do I do with it? They do a little 10, 15-minute lecture to start out with, and then after that, they'll just do case presentations. And so I always learn something on the 10 or 15 minutes, but if I have a case that I have questions with, they actually do an HIV lecture as well at another time. They do a PrEP lecture as well. So, if you're interested in that, that's super helpful. And that's why I'm giving that they have done great training for us. They can help with it and to make it super easy. So, hopefully I've convinced someone here today that they're like, you know what, Hep C, we can do this, that 2 drugs, minimal drug interactions, statins and proton pump inhibitors, and a 2-page form to fill out to get someone their Maviret, and only monitor them for 8 weeks. Our free clinic they had a person there for a while that actually they had trained with us as a resident and then was working there, and they're like, well, we can do it, because, once she saw how easy it was to do, that she was like, well, they're here, let me just fill out the paperwork and do it. And then when she's not working there, now they're kind of referring them over to us, and so we can help manage them through it. So I'll leave a little time for questions, or I guess if anybody I can send these. So and actually, I've got, if you want to send it to me, I can send you the Maviret, the Epclusa, just their paperwork that they require. It's easy to have it filled out. So that if you need it, send me your contact info if you need it, or if you have any questions on the slides or from there.
Obviously, it's good to know if a patient has HIV, and that's part of the screening, but does it change the treatment at all?
Not now. It depends on what they're on. Sometimes if they're on some of the older, and honestly, if you haven't done that before, that's maybe a group that I would pass on, to say, let me focus on what I can do. But now if they're on Biktarvy, which everybody takes Biktarvy for their HIV, you can still just write one of these two medicines. There's really the drug interactions. There used to be a harder, so if they're on an older regimen, so if they're not on Biktarvy, I probably would pass on that and say, I'm going to refer them over, but now it's not. The only thing that is if it's a new diagnosis of both, what the recommendations are, which I'm not sure why this is the case, but they're like, get them going on their HIV medicine. I think just because I feel like that's more important long term is to get them on a medicine. Because when there used to be drug interactions, I'm like, let me just treat them for 12 weeks and get their Hep C out, and then we'll just start them on their HIV medicine. And they're like, no, that's not the infectious disease way. The HIV is most important, so we need to do that first. But that's the only thing. It's something that it's a little, I have an up-to-date chart, you know what I mean? So like we've got a lab so I can do Hep B surface antigen, Hep B core, and I was like, okay, well, this is one option, this is the second option, third option, fourth option. This could be one of 4 options. But so if they have like a latent Hep B, we still treat them. And it was more of a theoretical risk that we were monitoring, that I don't treat Hep B unless they're an HIV patient, because then the Biktarvy treats it actually. So then even if they're latent. But it used to be more of a theoretical risk, but the benefits of treating their Hep C definitely outweigh the theoretical risk of Hep B activation. And they used to make a bigger deal about that, and now everybody's like, we're just not seeing it. Now we're 5 years, 10 years into it, and it's just, I've never seen it. And the ID centers that we work with are just like, it's want to know, because you're like, well, you should get vaccinated for Hep B if you've never been vaccinated for Hep B and you've had Hep C and Hep A as well, but it was more of an initial fear, and it's not something that we've seen. So we still treat them. Then we're like, well, even if they're late. Now sometimes I'll have to refer someone to GI, or because I'm like, well, I'm not sure what to do with this person from a Hep B standpoint. But when I ask my infectious disease guys, I'm like, well, how long do you treat them? And they're like, I don't know. I'm like, then I'm going to let you make that decision, because if you don't know, I don't know. If Dr. Ahuja doesn't know, that I'm like, we put them on Hep B medicines for a while. How long? Who knows? Well, send me messages if anybody wants, that if they have any more questions that come up, or if they need some, if they didn't get a slide off this, let me pray for them. Thank you for, the 4 o'clock lecture is tricky. I'm usually looking at, what Mexican restaurant I want to go to, or, how am I going to get some Italian, or, where I'm going to eat, or, so, thanks for coming to the 4 o'clock. And let me pray for us. Dear Lord, thank you that you have called us to treat everyone, and really more so than everyone, to treat the people that some people don't want to treat. Help us to be a witness for you in how we care for these populations that are just marginalized, that are put out to the side by our medical community. Help us to be a witness to those around us of the great care that we do to take care of these patients, and help us meet patients in their areas of greatest pain and show them your dignity, return their dignity, so that they thirst for you. Lord, let us continue to thirst. Help us to keep on drinking. Thank you for things that refresh us. Thank you for this conference. In your name we pray. Amen.